Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for your company. In this programme we take a look down throats, but before we begin, here's a quick word about Rural Health West's locum programme.
The locum placement service at Rural Health West is now linked to the Rural Health Select recruitment arm. Our locums come from metropolitan Perth and from country areas, and they undertake locum work to experience differences working within general practice, to broaden their experience, and also for the challenge of working within rural and remote communities within WA. Rural Health West actively promote our locum vacancies, and it's to cover for a doctor who is going on leave for recreation purposes, for professional development or when attending conferences, or when there is a need for a locum at your practice to fill a permanent vacancy while a permanent doctor is being recruited. We advertise your vacancy on our website and also fortnightly in our e-bulletins that we email out to all of our locums on our database and potential locums that may be interested in starting as a locum. Our locum assignments can run from 1 week to 4 weeks in length. We screen all of our locums to ensure that the locum that comes to your practice has suitable experience and qualifications to suit your practice. The Rural Health West Locum Placement Service do not charge fees or have any ongoing costs for your locum assignment. We assist the doctor and pay for travel to and from the assignment. We assist the doctor for applying for Medicare provider numbers and any hospital credentialing that they may require. For further information about the Locum Placement Service, you can contact us on 6389 4500, or you can visit our website where you can download one of our forms to advise us of your vacancy. We suggest you lodge your vacancy early, especially for holiday periods, just to give us a better chance of being able to fill your vacancy with a suitable locum.
Thanks, Wendy. Now let's get started. Professor Peter Friedland is an ENT at Sir Charles Gardner and Denise Bain is a speech pathologist. They join Dr Olga Ward now to discuss what is sometimes the neglected aspect of otolaryngology, throats.
Peter and Denise, welcome to the program.
Thank you.
Thank you. Hoarse voices are quite a common presentation in general practice. Most of the time it'll be a viral laryngitis, but they can actually persist for quite a long time. How would you assess what's going on in the office as a GP?
Well, you're quite right, they're very common, and as a GP it can be challenging to assess a hoarse voice because you don't always have the equipment like a laryngoscope, flexible laryngoscope to look at the vocal cords, and you may not be adept at using a mirror to do an indirect laryngoscopy. So I think that most of the assessment, like a dizzy patient, will come from the history. And common things happen commonly, and if you take a good history, you'll find that most people have either abused or misused or overused their voice. They've been watching the footy final, or they've been screaming at one of their children's swimming carnivals, and that's really been the problem. Or they've had an upper respiratory tract infection, and that's the commonest causes associated with a hoarse voice. And then, of course, there are other causes.
Denise, if somebody's over-screamed, how long would you expect them to be husky for?
If they're able to take some advice and try and rest their voice and try and get rid of some of those environmental factors that Peter was talking about, then the hoarse voice should resolve as long as they have oral hygiene. So things like stay away from caffeine and avoid air conditioning and
cigarettes.
Cigarettes, yes.
A hoarse voice can actually last anything up to 2, 3, 4 weeks. The problem with a hoarse voice is the difficulty in resting the voice. If someone has strained their ankle or their knee, you'd ask them not to walk on the ankle, you'll bandage it, you'll strap it up, and they'll look after it. Same with the voice, you'd like them to rest their voice, and it's very hard for a professional or someone who's working on a day-to-day basis to say you've got to be on strict voice rest for 10 days and just write down. So what we'd say is take quiet times during the day where you don't necessarily have to speak. Try texting. Using a mobile is particularly stressful because you usually tend to speak louder over a phone. Try speaking a more confidential voice. Try not to speak in a crowd. Drink lots of fluid because you do need hydration for the two vocal cords to vibrate together. And you know that when you're very nervous and your throat's very dry, you can't get the words out, or if you're dehydrated. The other important thing about hoarseness of voice, particularly in someone who's been overusing or abusing their voice, if they become hoarse, that's fine. But if they're a singer or a professional voice user and they suddenly lose their voice completely and become aphonic, you're worried about a small hemorrhage. There are lots of little blood vessels in the vocal cords and you can get a small hemorrhage. That is an emergency where the person needs very strict voice rest because that damage can be permanent.
As a GP, I've learnt to use a kind of indirect laryngoscopy mirror. We learn to use one as medical students, and I guess these are ubiquitous in country emergency departments where any more fancy equipment isn't. How much of a good view can you get, and how much of a diagnosis can you make with your quick glimpse of the vocal cords before the thing fogs up?
Well, I think you can make an excellent diagnosis, and I think it's a very adequate way of diagnosing major pathology within the larynx. And if that's a skill that you've got, it's outstanding, because up until about 20 years ago, before flexible endoscopes were available, that's what we all used, and that's what everyone else used, and many accurate diagnoses were made. And you can see laryngitis, inflammation of the vocal cords, you can see vocal polyps, you can see nodules, you can see malignancy, you can get a good idea.
In terms of a vocal assessment, Denise, what sort of extra things does a speech pathologist use?
Well, when we look at voice, we look at all the different parameters of voice. So we'd be looking at environmental factors for sure, but and how the person uses their voice, but also assessing across parameters of volume and pitch and resonance and rate as well. In a remote area, though, I don't know whether speech pathologists would have access to things like a VisiPitch machine, which measures pitch changes, or sound waves. We can have a look at a sound wave and see where there are episodes of dysphonia and where there are normal harmonics in their voice, and use biofeedback to help the patient to achieve a normal sounding voice, if you like. So perceptual ratings are very common and still probably used mostly.
Now, occasionally a patient will sort of say they've got this kind of chronically slightly hoarse voice, and increasingly GPs say the patient's been told, oh, it's just reflux, take some omeprazole. How do you know it's just reflux?
Reflux is different to gastroesophageal reflux, where the patients feel the heartburn, they feel the bloating, the regurgitation after a meal. Laryngopharyngeal reflux is called silent reflux, where they don't necessarily have these gastric symptoms, but they may have this frog in their throat or this lump in the back of the throat, globus sensation, and a kind of intermittent hoarseness and coughing after eating. Described about 20 years ago by Jamie Kaufman in the States, and when it came out, everybody hung their coat on this. This was the wonderful new diagnosis. Whenever you've got something in your throat that we can't diagnose, you've got reflux. It's overdiagnosed, and most people don't have reflux. And if you do have reflux, and it is silent reflux, and you do treat with a PPI, then the symptoms should disappear.
Within about a week? Or
if it's mild reflux, within about a week, but can take 6 weeks to 8 weeks for the symptoms to get better. What I tell patients is that it may not go away immediately, but they'll see a trend to improvement. And when one looks with a mirror or with a scope, one can see inflammation behind the vocal cords where the esophagus enters the back of the throat. And if a good trial of treatment doesn't work, then that's probably not the diagnosis. The other important thing about just giving omeprazole, if I may say,
yes, sure,
is that omeprazole is often given with a meal or after a meal. And it's a little bit like the horse has left the stable and now you're closing the door.
Yep.
Because there's an acid waterfall before a meal, and then they get the regurgitation. If you give the omeprazole an hour or two before the meal, it will control the acid output, so that when they do eat, there's no reflux.
Could you tell us about vocal cord nodules? Something that comes up periodically as a diagnosis, but I'm not really too sure what causes them or what makes them go away.
Vocal cord nodules are also overrated. They are really bilateral. That's the characteristic. They occur on both the vocal cords, and they occur the anterior front part of the vocal cords, which are the areas where the vocal cords bang together, and they're usually from vocal cord overuse or abuse. It's the biggest fear of a singer or a wannabe singer, and who's worried that they've got vocal cord nodules. The interesting thing with vocal cord nodules is they don't need surgery, and if they have adequate speech therapy and use their voice correctly, those vocal cord nodules can disappear completely.
Mm-hmm. So what would you do with them, Denise?
What would I do? I'd be advising the vocal hygiene that we've already talked about.
Sticky tape?
No. No. Things like avoiding air conditioner, drink plenty, as Peter said before, and avoid things like caffeine as well. I've been reading about this as well. I read about a teacher who had vocal nodules from getting whooping cough. He had lots, he strained his voice while he was coughing and he developed nodules. And he'd actually trained the children to only respond when he had a loud voice. So he was actually making his voice problem worse by teaching. So he had to rethink how he was approaching his teaching style, doing things like keeping people closer, trying to project your voice and standing tall, projecting your voice in a normal speaking voice rather than shouting or yelling.
We think that the vocal cords just move like this, but we've all got a basic frequency to our voice called a fundamental frequency. It's like our resting heart rate. So if someone's got a resting heart rate of 68 or 72, men have got a lower fundamental frequency, about 120 hertz, and women have got a much higher frequency, and that means that the vocal cords are coming together per second. My fundamental frequency is 120 times per second. That's how active the vocal cords are when you actually speak. So you can imagine when you shout and when you overuse it.
What about patients with other types of voice changes? I'm thinking of people with, say, Parkinson's disease, whose voices seem to start off fine and tail off to almost nothing. Can you do something for them?
You can. Ultimately, sometimes they can lose their voice and they sometimes get dementia as well. And they can't follow an instruction. But while they're able to follow an instruction, what I would do is get them to bear down, to take a deep breath and try and project their voice and try and do the opposite of what we were talking about with the vocal nodules. Try and get them to speak over background noise, because quite often I find that they do lose a perception of how loud their voice is, and so they might be speaking with very, very poor volume, and they think that they're speaking normally, so you need to tune them in to the actual volume of their voice by prompting them to speak more loudly and bearing down to get subglottal pressure.
The other important thing is, as you mentioned with the bearing down, is that the voice is really generated by the lungs. That's what generates the voice. The two vocal cords are just really the resonators. They don't produce the entire voice, and it's produced also through the nose and through the mouth and with the tongue. So if you can get them to take a deep breath and to use their lungs and to exercise that, then they can generate a lot of power that way.
So it sounds to me like if you've got Parkinson's or something that you're trying to rehabilitate, that you've got to be thinking all the time. It sounds quite labour intensive.
Absolutely.
I think the goal is quite often, more often than not, to maintain the skills that they have and rather than improve, because sometimes if they're on the downward slope, they get very frustrated as well.
So just trying to stay where they're at.
Try and maintain, and trying to give them pragmatic ways to get their message across, and even voice amplification as well, and possibly, ultimately, augmentative devices to help them to make their needs and wishes
very fancy.
known.
Are you talking about a portable microphone?
Possibly, yeah, not always. No, sometimes pictures work. I mean, there are low and high-tech augmentative devices to help people. There are really high-tech things that have, you can type right into the machine and press speak, and it will say the message for you, provided you can type right.
Yeah.
But there are all sorts of augmentative devices, but the other thing about these degenerative conditions is if people lose the ability to follow an instruction, then low tech may be the best way to
Pointed
go.
a picture on a picture chart.
Pointing at pictures, pointing at words if they're retaining the ability to read.
Yeah. Just before we take a break, could we talk a little bit about swallowing and the sorts of things that we should especially look out for in a patient who's got a swallowing problem?
I think your history is very important in terms of swallowing. How long has the swallowing problem been there? Has it been associated with neurological problems like stroke, multiple sclerosis, Parkinson's, or is this a sudden swallowing problem, a sudden dysphagia? And are they acutely unwell, and is there associated pain? And I'll come on to that. And then just look at the anatomy of the swallow. There are 3 parts or 4 parts to the swallow. The first part's the oral phase, where you've got motor control and it's voluntary. So if they've got problems with their teeth and their dentition, or an abscess in the mouth, or a quinsy or a tonsillitis, they'll have difficulty swallowing. And then if they've got a neurological problem, that'll be the second problem, and you'd worry about aspiration and pneumonias and that. What is an important clue is when a patient who's generally fit, healthy and well presents to your practice or to the clinic and says, "Doc, I've got unbelievable throat pain and I can't swallow my own saliva."
Yep.
And that should raise enormous alarm bells, because you'd be worried in an adult that that's a supraglottitis or an epiglottitis. Because how the patient presents is with an intense pain in their throat.
Yep.
As a general practitioner, if you haven't got a mirror and you're not able to look down, you can't really see the epiglottis. And when you look in the throat, everything looks fine. Patients are a bit tender over the neck. They may or may not have a fever, but they get an acute swelling of the epiglottis, which prevents them from swallowing, so their saliva accumulates and they may drool a little bit, and their airway can close off within hours. So I think when you see a patient like that, alarm bells.
Yeah. Now, we don't see a lot of epiglottitis anymore since the vaccinations all came in.
Yes.
And thank God I never want to see it again. It's obviously still around. Is it the same bacterial causes or something completely different now?
It's viral and it's bacterial, and despite the fact that there's been the Hib vaccine around for Haemophilus influenza, we are seeing it a change of season. And in fact, at Charlie's, we can get an admission almost on a weekly basis during the change of season. So we see it very, very frequently. I can't say the same for the Children's Hospital because I'm not working there, but certainly it's not as rare as one thinks. And we've had 2 referrals from general practice from very astute GPs who've called an ambulance and sent the patient straight in.
Yep. So now this is the same kind of classic presentation that you used to see with children with Hib. So they'd be leaning forward, drooling,
Correct.
desperately trying to keep an airway going.
Yes.
How would you treat that if you're in a more remote area and when you're the doctor at the hospital as well as the doctor at the surgery?
Well, I think there are 2 principles. Keep yourself calm.
Yep.
Keep the patient calm, because if you get these patients uptight, it'll make them a lot worse. Don't manipulate the airway. If you can, get up an IV, and if you're able to, you can give them adrenaline nebulization. If you can transfer them to a hospital where there are specialized facilities like an anaesthetist available or a surgeon for a surgical airway if needed, then you would want to do that. If you're capable of doing that in your own practice, then you may want to watch the patient. But it really is a diagnosis with a very high index of suspicion. You won't have a firm diagnosis unless you've had a good visualization or you're able to do a lateral x-ray. And if you do a lateral x-ray, you look at the tongue base, and instead of seeing a small little leaflet for the epiglottis, you'll see a big thumbprint. And that will give you a clue that there's a problem there. Adults tend to present a lot quicker than children because they have this intense inability to swallow and they can verbalize it, and they'll usually go to their GP, whereas children don't.
What sort of other simple things, just getting back briefly onto swallowing, what sort of simple things could a GP do in their surgery? Is there something that we could or should do? Should we be viewing a patient doing a swallow, or should we leave that all to the speech pathologist?
To do what, Olga? To treat them or to
just to make a
diagnose
diagnosis,
them?
I think.
Well, I use cervical auscultation quite a lot. And that gives me information about how food and fluid is going down and whether it's going down the right way.
Yep.
it gives me information about whether there's appropriate glottal release to resume the normal breathing cycle after somebody's swallowed.
Okay, so just tell me what you would hear if you were auscultating somebody's
neck. You'd hear
neck.
the fluid. You'd hear the fluid.
You actually hear it gurgling around in the larynx.
You can hear laryngeal pooling. You can hear it. And I listen for their voice.
Mm-hmm.
So if they've got a gurgly voice, I know that it's at risk of going into the airway. I listen to the resumption of normal breathing pattern. And if that's not within normal limits, it tells me that the person's struggling on that texture. Or that fluid, and I would ask them as well, because sometimes people have a fear of choking if they've experienced a choking instance.
Mm-hmm.
I would ask the patient as well if they were able to self-report. The problem in the place that I work with adults is that if people have an inability to self-report, then we have to look at dependence.
Mm-hmm. So
eating and drinking as one of the major causes. It's considered to be one of the predictors of aspiration pneumonia, really, if people are more dependent, because it means that they're not eating or drinking at their own rate. They can't do it themselves. So,
what do you do for these patients? Mostly thickened fluids in your case?
I try to modify the environment first. For instance, reduce distractions, help them to concentrate. I might give them certain manoeuvres to do to help them to swallow more effectively or more efficiently to protect their airway. Strengthen their pharyngeal wall if they're able to do that. There are several things that we can do to help them to do that, and there are several things that we can do to help them to get the correct positioning so that they can swallow more safely. Chin tuck is an obvious one because...
Close off the airway.
Yes. And also asking them to pretend that they're swallowing a hard-boiled egg to get that effortfful swallow, we call it, so that they can swallow without having residue.
Yep. Is there anything extra or magical that ENT surgeons do for these patients?
I think there's, just to add, what you've said is absolutely correct, but certainly when you're doing a swallow assessment, does the patient have a gradual loss of weight? Because they might be silently aspirating without coughing, and that'll lead to a gradual loss of weight and condition. The other thing is, I think it is useful to get them to drink, and if you're worried about them aspirating, give them some clear fluid or some water and see what happens. If they can swallow a glass of water or a couple of sips of water and there's no coughing, it's highly unlikely that they're actually aspirating, because you need a lot of coordination for a glass of water. And then you can do the various manoeuvres that you've mentioned. For example, tucking the chin when they swallow to see if that improves it and they don't cough after that. If they've got a left-sided weakness from a stroke, you'd ask them to tuck their head to the left, because that will close off the left side of the hypopharynx and the pharynx, and will allow the water or the food to go down on the good side. For a more specialised evaluation of swallow, you could send them for a barium swallow or a fluoroscopy or a modified barium swallow, and that's when you get the patient to drink some barium and you film it going down.
Yep.
It's a two-dimensional study, but it can be done in certain centres. What we now do, and it sounds very complicated, but it's very simple, is we put a flexible endoscope in the nose and we put it at the top of the throat, just behind the soft palate, and then with the speech pathologist we give them different kinds of food to eat and to drink. And we dye the food with a colorant like the Robertson's green dye. Give them green milk or green puree, and you watch what happens with the food. And on the screen, on the endoscope, and you can see if the patient has a problem with the delayed oral phase, or whether the food gets stuck, whether there's residue of food and they don't clear it, whether it penetrates into the airway, and whether they're able to clear it or whether it gets aspirated. Endoscopic evaluation of swallowing is available certainly at Charlie's, it's certainly available at the major hospitals here in Perth.
Yeah. What about some of the ENT surgeons who visit regional areas? Would they be able to take the equipment with them? Is that something that you would normally do?
Yes, there's a flexible scope up there, and that's all you really need. And that could be done. You could do a flexible evaluation of swallowing.
Brilliant. So, for instance, if a GP was referring to their regional ENT, they could ask for something like this? Yes, not all ENTs are trained in swallow, and it does need expertise. And if there's a speech pathologist who's got a swallowing interest in swallowing,
then you would ask that you would involve them. Yeah.
Fantastic.
When I'm seeing people, I don't always have access to video fluoroscopy either, but I think it always pays to remember that when you're doing a video, because it's live, you've only got a snapshot of what is happening for that patient at that time, and to be aware that swallow does change across a day, and it can vary from meal to meal, can't
Correct.
it? Because, for instance, in elderly people, and in people who've had strokes, I guess as well, they might have a best meal. So if you're trying to optimise their intake for nutritional reasons, then perhaps you'd find out which meal was the best meal of the day. Maybe it's breakfast, maybe they're too tired at breakfast, maybe it's dinner time, maybe it's lunchtime, and following them over the course of the day.
And we'll be back with that discussion in a moment. Dr. Rod Steens is a pneumologist based in Subiaco. In this segment, he discusses the setup and use of continuous positive airway pressure machines in the treatment of sleep apnea.
Rod, sleep apnea seems to be becoming quite common in our society. Could you just tell us briefly about the diagnosis and how it's made?
Yes, I think it seems more common because of relative unawareness, particularly a few decades ago. And obviously doctors and people in the community in general are much more aware now.
Yeah.
But also the so-called obesity epidemic no doubt has tipped the balance. And obesity increases the likelihood of obstructive sleep apnea in various ways. In terms of the diagnosis of sleep apnea, traditionally, of course, as with most medical problems, it's suspected out of the history. So there's the partner complaining about significant disruptive snoring often, which may or may not be postural. Witnessed apnea. The patient themselves may become aware of snorting or gasping or choking arousals from sleep.
So these are the sorts of patients that say, oh, I'm just never rested and I'm waking up all night.
That varies quite a lot. Some patients will perceive the sleep disruption or some of it. Others are completely unaware, think they've slept extremely soundly and don't understand why they feel unrefreshed in the morning, given that they've apparently slept soundly all night. And of course the daytime symptoms of lethargy and somnolence, and also whether they become aware of snorting, gasping, choking arousals.
Yeah. And if a GP is working up a patient thinking that they probably have sleep apnea, before they send them off to a respiratory physician, are there any particular tests or things that we should do?
Yes, there's a few things to address. It'll be suspected on the examination findings, perhaps by an impression of a crowded throat, meaning that structures in the throat seem closer together in that individual than a group of patients where they wouldn't snore. Then, of course, obesity, alcohol consumption, and from a lab point of view, if there's any suggestion of underactive hypothyroidism, then that can be a predisposing factor as well.
Understand that it's possible for a patient to have some equipment sent out to their home in the country to do a form of sleep study, but I know that a significant number of patients still come to Perth and do an overnight study in the lab. What sort of different information do you get from those two studies, and is the at-home option adequate for most diagnoses?
So the basic would be just nasal pressure monitoring with or without oximetry, which obviously gives you some information. It may be confirmatory. If it's negative, it doesn't mean one hasn't got sleep apnea. And then the next level up would add on other aspects such as rib cage and abdominal motion traces, in addition to the nasal pressure and the oximetry. And then there may or may not be a posture trace as well, and possibly even monitoring for leg movements with EMG of the legs. And then the next level up is what we call comprehensive monitoring, which to some extent can be undertaken at home, and then even more sophisticated monitoring can be done in the sleep centre, as you've alluded to.
This is a comprehensive sleep study setup. And basically what we have is we have EOG for eye movement, so we can tell when a patient's in rapid eye movement. We've got EEG, so we can tell whether the patient's awake or asleep. And if asleep, we know which of 5 sleep stages he's in.
So these are your eye movement?
Yes, the ones here.
Yep.
We have EMG, which is
So
muscle
they're
tone.
grinding their teeth?
Absolutely, and also it's part of the criteria for identifying REM, that we lose all muscle tone, so that one will help us in our staging.
And I notice you've got 2 probes up his nose, which I'm sure must be
yes.
very comfortable.
We have airflow, a thermistor, which will detect movement of air, both nasal and oral.
Yep.
And we have nasal pressure, which are the prongs, the cannula. And that only detects nasal breathing, but it's a far more sensitive measure, so that's why we have both of them.
And then chest and abdomen?
Yes, for effort, so not only do we have airflow and nasal pressure, but we're also looking at the motions of breathing, so that if there's any reductions in the airflow, we're also seeing if there is a reduction in their effort to breathe. And in some instances in central apnea, there's absolute no movement in the effort, so that helps us categorise the different types of events. We also have a position monitor, which we can verify when we're doing an in-centre with the infrared camera, that we can verify that the position monitor is actually correct.
Okay, so you're filming
Yes.
basically a whole night's sleep.
Yeah.
Must make very exciting viewing in the morning.
Yes, it does, but it's important. Certainly there is REM behaviour disorder, so you know, it's very useful to have the digital video in that instance.
Yep.
If we have paediatrics, sleep analysis heavily depends on the visual aspects of the video.
Yep. How much information do you lose with the patient being uncomfortable, being in an unfamiliar environment in a you know, hospital type bed rather than in their own bed with their own manky pillow and their teddy bear?
Well, comparative studies have been done, and for in-centre, in-sleep laboratory patients and for sophisticated home monitoring, the sleep efficiency is about 75 to 80% for both. But, of course, 3/4 of the night, 80% of the night of accurate data is a lot of data out of 8 hours of sleep. And so, you know, 6 hours good data is extremely helpful, even if the patient doesn't perceive that they slept as well as they may have at home.
Could you run us through the options if once the sleep apnea is actually diagnosed? What sort of things can the patients look forward to in terms of treatment?
Yes, and as you might have alluded to earlier, one of the things that the general practitioner can focus on during the referral process and even before is looking at the aspects of weight reduction, alcohol consumption if it's relevant, excluding the hypothyroidism if it's possible. And also really trying to shape up any nasal obstruction, treating allergic rhinitis. Not uncommon for me to see people who have subacute or chronic sinusitis, parallel sinusitis, infective in origin, that the patient really hasn't alluded to the doctor, therefore hasn't been addressed. So those things are very important, and often, of course, they're the focus of our conversation, our consultation following the sleep study and indeed before.
So is it worth us doing imaging of sinuses before the patient comes?
Only to the extent where one would normally do it. So if it's seen, meaning if the patient really presents with those symptoms, then you would do a CT scan if and when you would in the normal process of management of that patient. But not especially just because they're being referred for sleep disorder. And then with the other treatment options, really, if one was looking at the order of things, CPAP, of course, because it works essentially all the time, is at the top of the list.
Baby CPAP machines seem to have shrunk over the years.
They They sure have. They're smaller, quieter. They also have a lot of features that make them a lot more comfortable for the patient.
And this looks like two units stuck together. What are they?
Well, the compressor part of the device is actually one half, and the other half is a heated humidifier. And the reason the heated humidifier is actually of benefit to the patient is because it adds warmth and moisture to the air, so it's far more friendly for the nasal passages.
Yep. And when the patients come home and they bring one of these, how do they set themselves up?
Well, they're incredibly simple, and the patients really need to realise that there's nothing they could accidentally press that would change their settings. So the actual setting mode is very difficult to get into, and so it's very unlikely, even if they press buttons in the dark, that they will change their settings. So the best thing is to actually get as much information when they obtain the machine, and just get to familiarise themselves with all the different buttons.
Yep. And do they have to wear like a full face mask these days?
No, in fact the full face mask is the last option when we can't control a mouth leak. The nasal masks are very good.
Could you show us one of those?
Sure. We have two basic types of nasal masks. This is one of the latest nasal masks. They're very light, and the exhalation port makes them very, very quiet. They've
So can we
certainly
stick that on our model?
Now, I think one of the most important things to keep in mind when you're choosing a mask is you want to obtain two things. You want to obtain a good seal, but also a lot of comfort. So, and the mask should allow you to sleep in all postures. So if you have got a mask and it doesn't allow you to sleep how you normally would sleep, then it's probably not a good mask. I mean, with everything, there is a time that you need to give it to get used to, because it is quite a different way to sleep.
Yeah.
But certainly a mask shouldn't hurt, it shouldn't cause abrasion. If it does, then you certainly need to investigate your different options.
I hear that lots of patients swear by magic snore strips. Have they got any efficacy at all?
As in external nasal dilator strips. Can be a bit positional, can be a bit irritating for some patients as well. But essentially, when you let go, it wants to straighten out, so it has some stiffening in it, which tends to pull out the other nasi, which can improve nasal airflow. The effect of that, in adults at least, is mostly to improve snoring. Might improve sleep apnea a little, but typically the sleep apnea is much more to do with to do with the pharynx.
So what are these other things that you've got here, Rod?
Well, another way of providing abduction of the outer nasi during sleep is this device, and that sits in the nostrils, and obviously when you let go it tends to push the outer nasi out.
Very medieval, that.
Yes, but it's still around. Again, it can be irritating unless it's tethered with a bit of tape. It can tend to run around the bed rather than remain in the nose. Yes, and I guess the mouth guards come second in line to CPAP, and for mild, maybe moderate sleep apnea, the chance of them working adequately might be around, say, 50%. And of course, the idea is to have an upper and a lower guard with an adjustable mechanism between the two, if it's an adjustable device, to keep the lower part further forward. And so when it's in the patient's mouth, it advances the mandible and hopefully creating more space in the throat. But with this one, you have an upper and lower plate. It's this particular arrangement on each side which allows for the lower part to be kept further forward, and there's room for adjustability in this aspect on each side as well, and one uses a lever. And one
does
leverage...
the patient adjust it themselves, or is this they see the dentist to get it moved around?
No, generally the dentist will instruct the patient about how to do that and give them a feel for how often and how quickly to do that, of course, depending on how tolerance goes, because the mandibular advancement appliances, of course, can place strain on the temporomandibular joints, the jaw musculature, and even the teeth themselves. So it's a steady pace. It's not stick to a rigid program and get into trouble with those sorts of side effects. And then the other sort that's fairly commonly used in terms of the more sophisticated ones is this so-called MDSA. The maxillary portion has a metal plate, and the adjustable part of it is on in the anterior aspect of the mandibular portion. And with use of an Allen key inserted at the front, winding this will gradually bring that hook further forward, which of course in turn brings the mandible further forward, given that the upper portion is anchored to the maxilla.
And most patients are quite worried about cost. These are extremely expensive?
Depends on one's definition of extreme, but yes, they're not cheap. Over the period that this all happens following a sleep study, the out-of-pocket expenses may not be very different between CPAP and the mouthguard, depending of course on how it all unfolds and how well the patient gets used to it all, and how much extra involvement's required.
And our thanks to Dr. Steens for his time. Now let's return to our discussion with Professor Peter Friedland, Denise Bain and our own Dr. Olga Ward.
Speaking of sore throats, I have seen some really huge tonsils in kids who've got practically no problems, and some who can hardly speak or swallow every time they get a mild sore throat. What's the cue for taking tonsils out these days?
That's a good question, because it's not always the case that size matters. And in the olden days, we used to call all the tonsils out in children who were 3 or 4 years old for recurrent tonsillitis. Yep. And the entire trend has changed. 3/4 of children who used to have tonsillectomies were because of chronic tonsillitis. Now it's only 1/4 of all children who have tonsillectomies are for recurrent tonsillitis, and 3/4 of them have upper airway obstruction. Yep. Or they have sleep disordered breathing. And when a child has large tonsils on their own, but they have no associated symptoms, you would not think about removing the tonsils. Mm-hmm. Their airway will develop, their throat will develop, and they're not getting recurrent tonsillitis, you leave them well alone. But if they're a child that is that breathe through their mouth, all children are obligate nasal breathers, we all breathe through our nose, they breathe through their mouth, they snore heavily at night, they have a restless night of sleep, superficial sleep, they don't go into a deep REM phase, they wake up tired in the morning, they have behavioural issues at school. They may have enuresis, bedwetting, because we know that ADH, the antidiuretic hormone, is secreted through the deeper phases of sleep. They may have a failure to thrive, because we know growth hormone is also secreted through the deeper phases of sleep. So if a child presents like that with enlarged tonsils, probably the most successful way of treating upper airway obstruction or sleep disordered breathing in children is removing tonsils and the adenoid. Mm-hmm. And that's the real indication in those children. If you're looking at it from a recurrent tonsillitis point of view, the indications are pretty strict. Usually up to about 7 episodes of proper tonsillitis in a year, or 5 episodes over 2 years, or 3 episodes a year for 3 years.
And adults? Do you take adults' tonsils out?
Yes, we do.
Same kind of indications?
Same kind of indications, far less successful in terms of treating their snoring and their apnea, because there are other issues involved, including a large tongue base and a palate and increased weight gain and also decreased muscle tone as we get older. But we find that a lot of adults in their late teens and early 20s get recurrent tonsillitis, usually from a very bad viral infection. They developed tonsillitis as a child, they outgrew it, they never contemplated having their tonsils out, and in the early teens they started developing really bad recurrent tonsillitis associated with myalgias, arthralgias, taking time off work, and that's usually associated with a very significant episode of Epstein-Barr virus glandular fever, which is known as kissing disease, and they pick it up with droplet spread, and once they've had a very bad episode of that, it tends to scar their tonsils. And then they tend to get these current episodes of tonsillitis. Another indication for taking out tonsils in adults is that young adults will present complaining of halitosis.
Mm-hmm.
And we often see that in general practice.
Kind of
and you can see
thick,
those
inspissated little
yes,
chunks
you see
of
those
pus in
little
there.
white chunks or bits in their tonsils, which we think is pus. They're actually stones, tonsilloliths, almost like you can get a cecholith in the colon.
Yeah.
And it's just a hard piece of inspissated debris, saliva, food, and it accumulates and it really stinks. And some patients are quite adept at removing it from their tonsils, and they poke it out and the tonsil gets a bit inflamed. So it's one of the indications for removing someone's tonsils.
Mm-hmm. Do big tonsils interfere with children's speech development at all, Denise?
Well, the thing that popped into my mind is that sometimes I see children who've got middle ear infections at the same time as tonsillitis. So if the recurring tonsillitis is due to middle ear infections, then sometimes
All right, so
they need
just
be
to
able to
cue
hear
that
properly to do the
if they can't
therapy.
hear, they can't speak.
Exactly.
Well, I think if you come back to that speech issue, it's a very important and it's quite a contentious issue in terms of speech, enlarged tonsils, removal of the tonsils. In a child who's got upper airway obstruction, they can have a blocked nose and hyponasal speech. In other words, they can't get enough air through their nose and they can't pronounce their nasal consonants. So in GP practice, it's a very easy and useful thing to say to the patient, say for me 99 bunnies. And then they say 99 bunnies, and then you ask them to block their nose, say 99 bunnies, you can hear that I've got some nasal speech. But those children who've got a blocked nose will sound the same irrespective. Those children will improve after removing the tonsils and the adenoids, but one has to be extremely careful when one removes very enlarged adenoids. First of all, you can have what's known as a submucous cleft palate. In other words, when you look inside the mouth and you look at the hard palate and the soft palate, it all looks normal.
Yep.
And it's covered by a membrane, but when you palpate it with your finger, there's no bone there. And what's keeping that palate competent is the adenoid tissue. And when you remove that adenoid, they become hypernasal and they get this Donald Duck, very squeaky voice, and they get regurgitation of food through the back of their throat. So it swings both ways, the pendulum. We would recommend removing adenoids and tonsils for obstruction, but not in the presence of a submucous cleft palate.
Is that something that an ENT surgeon would always look for before they take out adenoids?
Yes,
Is
they
that
should.
something the GP should be looking for?
GPs don't need to look for it, but an ENT should be looking for it. And even in the absence of that, when you have removed an enormous amount of obstruction at the back of a child's nose and in their throat, their voice will go from a completely blocked voice to a hypernasal squeaky voice, and parents will complain. But as long as there's no cleft in the palate, it'll come back to normality. So for the first 2 or 3 weeks, these children do sound strange.
The other thing that I was just thinking about as well, when children come to speech therapy and they're not well, whether it's because of tonsillitis or whether it's because of any other illness, it does affect their concentration. So I've had a little boy who has just come in to see me last week, and he was much more able to concentrate and much more sort of with it because he'd just got grommets. So it's a different boy.
Now he can hear you. And
now that he can, and it's affected his concentration in a positive way.
just before we leave the sore throats, the terror of all GPs is that they will have a look down somebody's throat and find a quinsy. Do you have to lance it?
No.
Good. What do you do?
So a quinsy is, and I'm sure all your practitioners know, but a quinsy is a peritonsillar abscess. It's an abscess that's next to the tonsil that pushes the tonsil towards the midline, and so you see a patient who's got a unilateral tonsillitis. And there have been lots of studies on whether you have to do an incision and drainage or you can do a needle aspiration. And if you're worried about hitting the carotid, you'd need to do neither. You can give intravenous antibiotics and some steroids. If the airway is a problem, you may need to do a nasal intubation, but then you would be referring the patient on. But you don't always have to drain the abscess.
What about congenital things? You talked about cleft palate and the submucous cleft palate that you may not have had picked up. Are there any other structural kind of congenital things that may affect somebody's throat or their swallow or their speech that maybe we should be looking for?
Well, I think the commonest one is cleft lip and palate. And we all start off in life with a cleft, which is a space or a split between the palate. And at about 6 to 11 weeks of embryonic development in early pregnancy, the lip joins together and the palate comes together. And when there are problems in an early pregnancy, for example, related to alcohol or to drug abuse, or some hereditary situations, congenital abnormalities, you get the palate not joining together in the midline. And the major problem with that is these babies are born with a gap in the roof of their mouth into their nose. So their speech is affected. They don't speak when they're young, but their feeding is a problem because all the milk goes through the nasal cavity. They can't latch onto the breast. They can't use a normal teat on a bottle to suck. And they have huge swallowing and thriving problems. And then basically what happens is the eustachian tubes, which drain the middle ear, are basically a cartilaginous muscular tube. And those muscles are the same muscles that develop from the palate, from the soft and hard palate. So these children have middle ear problems from the day they're born till well into adulthood. And they have recurrent ear infections with fluid in their ears. They're born with fluid in their ears. And this leads to, of course, decreased hearing, decreased concentration, and recurrent ear infections. So that's probably the commonest congenital abnormality, 1 in 1,000 births.
So it sounds very complicated. If you are in a country area, how much assistance can you get? Is this something that obviously the child is going to have operations and fancy equipment and bits and pieces that come from Perth, but are there any things that can be done to help out in a regional area? And what happens to the country speech pathologist who kind of cops a 2-year-old with a cleft palate?
I think there'd be a lot of liaising with PMH, but we'd be dealing with what was presented at the time. We'd be coping with the speech difficulties that the child had at the time, and until they went in for the next operation, they do have to have quite a lot of different...
Ideally, a cleft palate child should be dealt with in a multidisciplinary meeting, ENT, plastic surgeon, orthodontist, dentist, speech pathologist, dietitian, psychologist or social worker. That's not always the case.
Yeah.
And I think that if you are aware on an antenatal scan that the child has a cleft, that child should be referred to a major centre. And parents should be aware and prepared psychologically for the shock that they get at birth. Yeah. Because not only the shock of seeing their baby who's perfectly formed but with this deformity is very confronting, but the fact that these children can't drink. And so we have, for when they're born, and that can be used in a rural area, special teats that are longer teats that don't allow the milk to come out as quickly, that direct the milk more into the mouth and not up into the nose. That can be used. When they're a little bit older, we actually put in an obturator plate at the top of their mouth that blocks off the fistula or the connection between the mouth and the nose, and those children can be managed in the rural areas quite comfortably. The lips are usually repaired first at about 10 weeks after birth. Yep. And then the palate's repaired at about 9 to 18 months, depending on the growth. But these children all require long-term follow-up. It's not just one operation, because the teeth are continually developing, the maxilla is developing, the ears are developing. So it's an ongoing management problem. But those problems can be sorted out in the rural areas.
Yes, you'd be looking at different milestones and comparing, treating a developmental delay, really, wouldn't you?
And I guess these families then become intimately acquainted with the PATS system. 2 more little things. Do you ever treat tongue tie? And if you do, how do you do it? When do you do it?
Okay. So the tongue tie is the frenulum at the base of the tongue. It's this cord that actually directs the development of the oral cavity and the front teeth. We've all got it, but it usually recedes. And in some children it doesn't. The question is when, as you've said, when do you need to treat it? If it affects speech at a later stage and they're unable to pronounce certain consonants and words because they need to move the tip of the tongue, if it affects swallowing, if a child's unable to put their tongue out and lick
Ice cream.
an ice cream or a lolly, then that would be a problem. In tinies, in little babies, if they're unable to latch or unable to suckle or to drink, then you could treat it. It's a very simple procedure. When they're very young, a couple of weeks old, you can actually do it under local anaesthetic in the rooms, and you simply incise that tongue tie. And when they're a little bit older, it's also a very simple procedure, but usually done under an anaesthetic. And you simply cauterize or cut across the actual tongue tie itself, and you release it. It takes 2-3 minutes to do.
Yeah.
I think for feeding problems, definitely, I mean, I'd be referring somebody to an ENT, but I think when children are a little bit older, they do tend to adapt to the structures in their mouth, and if you teach them where to put their tongue, that sometimes they're able to pronounce.
Finally, country patients who unfortunately feature very large in the road accident statistics sometimes end up in intensive care, intubated for a very long time. How do you get their larynx back to normal function after they've had a tube, or in some cases a trachea, for a while they've been artificially ventilated? And does it ever come back completely to normal?
You have to take into account the circumstances of the accident and the long-term sequelae of the accident. So removing an endotracheal tube is problematic, and it does take a while for their reflexes to recover and to start breathing adequately and using their own ventilation. The problem is what are the associated injuries? Is there a head injury? Has there been a lung injury? Have they been in ICU for a long time? Are they muscle wasted and very weak, because that will also cause problems? Are there underlying cord palsies? And certainly the problems associated with long-term ventilation. They can develop a subglottic stenosis, where the tracheostomy was sitting and a narrowing of the trachea. They can develop granulomas on their vocal cords. They can be chronically aspirating acid. So there are an enormous amount of problems that can be associated with long-term endotracheal tubes. It has to be done very carefully, very slowly, and taking the whole global picture into account.
So if these patients lob in, just suspect those, because they sometimes will be transferred once they're in the rehabilitation phase to their regional hospital or their local hospital. Do we still need to be aware of this, or is this something that would have normally been sorted out in the ICU area?
They would be referred to you with a tracheostomy in place, or they may have been referred to you extubated with no tube. I'd like to think that all those problems would have been taken care of here, but I don't think so. And I think one needs to have a high index of suspicion that there may still be a stenosis beneath the trachea site or granuloma. There may be vocal cord granulomas. There may be problems.
So something for early assessment and
Yes,
specialist liaison for either profession.
And I guess for any rehabilitation, the salient thing for a speech pathologist would be, are they able to participate in the rehab, and regardless of whether it's deemed appropriate medically, but can the person follow an instruction to do what needs to be done to participate?
Thank you so much for joining us and for covering so many topics in such a short time. Does either of you have a take-home message?
I'm just thinking about all those remote people out there who might not feel that they're connected with services, that, you know, there is collegiality out there, and to keep up the contact, really. That would be my message, to make sure that...
Keep liaising with your colleagues.
Keep speaking with you and colleagues, and embrace the wider team, really. It's like a big team.
Peter?
I would echo those sentiments, and I think people down here would be more than happy to take telephone calls and advice, and offer advice if necessary. And I think trust your intuition and your common sense. Common things happen commonly, and doctors in rural areas are very talented and very experienced. And I think if they follow their sane judgment, when it comes to airway issues, when it comes to sore throats, when it comes to swallowing problems and congenital abnormalities, I think they'll cope with 95% of anything that's presented to them, maybe more.
And that's all the time we have for this program. We'll be back on the 6th of November with a program looking at how modern technology can impact your health. I'm Jerry Gannon. Thanks for joining us once again.